I am Taylor, and I'm one of the addiction medicine fellows for folks joining us. My topic is kind of going to be regarding methadone inductions in the hospital and a rapid titration protocol. No disclosures. Here are some of the objectives for today. So discuss standard methadone induction protocols, give a basic overview of methadone, and kind of go through some of the changes in the fentanyl era, review the protocol that was used for this study, and then talk about some of the contraindications to doing this rapid induction and the safety profile, at least that was published here. So here is the article name, piloting a hospital-based rapid methadone initiation protocol for fentanyl. It was a study that was published this year in the Journal of Addiction Medicine and was run out of OHSU. Just to give a little bit of background of methadone, I know this is probably a review for most people, but let's see if I can. Oops. There we go. So methadone is synthetic, it's long-acting opiate. It's an opioid agonist, and then it also has action at the NMDA receptor as an antagonist. In terms of FDA approved uses, moderate to severe pain, and then opiate use disorder, both with indications for detoxification and treatment. One of the really interesting things about methadone and one of the issues it causes with us working with it in the hospital is that it has a very variable half-life. So 6 to 120 hours, depending on your rate of methadone, whether you're a fast or slow metabolizer. And that means that you're going to take 5 to 7 days to be at a steady state. So really requires some nuance when thinking about starting it. There is seen to be increased mortality during methadone induction when used for opiate use disorder. But there's tons of studies kind of reporting on the benefits. So decreased illicit opiate use, decreased crime, decreased HIV and other infectious diseases. Another kind of thing surrounding methadone that I think we're all aware of is that it's highly regulated. So not only at the federal level, but also at the state level, which is very interesting. There have been a lot of changes in the post-COVID era, specifically regarding take-home dosing. And so this is kind of just like an illustration on the side there of different states that have adopted kind of the more updated recommendations from HHS regarding take-home dosing. So now you can get, I think it's 7 days of take-home dosing after your first visit to a methadone clinic. So that's one of the changes, and we have adopted those changes here. But as you can see, if you go over to the border to Wisconsin, the laws are different there. So some more on methadone. So the reason I think this paper and similar papers are important is because the fentanyl era has really changed things. There's just like an unprecedented amount of opiate tolerance that we're seeing in patients. And so the historically therapeutic doses closer to like the 60 to 90 milligrams no longer are working to control people's cravings, people's withdrawals, and therapeutic dosing is more at the 90 to 100 milligram level. This is the protocol that they cite in this specific study as like a standard inpatient protocol. It's the one I've been using at Hennepin and seems to be still faster than what was done like years ago, certainly, but you can get somebody to 60 milligrams in a matter of a few days. And that's still faster than what they're doing as an outpatient. So the traditional like outpatient OTP initiation, it would take you 2 weeks to get to that therapeutic dosing. And why do we go slow with methadone? Obviously, with that half-life, there's concern for safety, there's concern for oversedation. When you discharge someone from the hospital specifically, you're not really observing somebody reaching that steady state. So there's just like a lot of nuance, like I said, and other implications. This study was a retrospective chart review. One thing that was interesting, and I think it's definitely a strength of this study, so the patients could receive short-acting full opioid agonists on top of it, and they kind of characterized how much MMEs everyone got. They said they reviewed all of the indications to hold the methadone dosing with both the nurses and the patient. So things like respiratory depression, overly sedated, they were holding doses. If the patients were still there after day 7, they could go up on the dose because the protocol that they had more specific parameters for only went through day 7. And basically they just looked at the chart for demographics, what their diagnoses were, whether they had been involved with MOED before, and like I said, the total MME received. Adverse effects, so that was the main thing they really watched for during this study, and they defined it with 3 different parameters. They said if you held a scheduled methadone dose, that was an adverse event. If you had to be administered naloxone, concern for overdose, obviously that would be an adverse event, and then any transfer to a higher level of care. So going to the ICU or a step-down unit would be also an adverse event. This is the protocol they used. So they have max dosing in a day, and then they have kind of how to get there. So it's a lot of the 10 milligram PRN for persistent withdrawal or craving symptoms to get to 100 milligrams after 4 to 7 days. So a pretty rapid titration when you think about like the differences between this and the other table that we were just looking at. The other table, just to remind you guys, was starting at I think it was 30 milligrams, 40 milligrams, and then got up to 60 on days 3 through 6 versus this at day 4 through 7, you can be up to 100 milligrams. So a big dose difference too when you're thinking about your therapeutic dose range being closer to like 60 to 120. Patient selection. So they were pretty specific with who they allowed to be a part of the study. Inclusion criteria was routine fentanyl use, and they just said anyone who was using opiates who said that fentanyl was their main opiate of choice. They had to have an addiction medicine consult because that's how the study was run. Exclusion criteria, so any end organ failure. So they looked at kidney disease, liver disease, heart failure, lung disease. They said you couldn't be in the study if your QTC was greater than 500, given the risk for QTC prolongation. They said no concurrent benzos or alcohol use, no medications that could affect methadone metabolism. They included only younger patients, so their cutoff was age 65. And then you couldn't have been on methadone through an OTP within 7 days of admission. You couldn't have transitioned from another form like bupe within 2 days of admission. This is kind of their exclusion table that they went through.
Taylor, I have a question. You
Yeah.
said it was a retrospective study, though.
Yep.
So they had set up this protocol and that's what they were doing, and then they looked retrospectively?
I guess so.
Or
They were already doing it.
they were already using this protocol?
Yep, exactly.
Okay, sorry.
Kind of an interesting way of doing it because they probably had in the back of their mind that they might want to publish.
They just kind of didn't get around to it up front almost, it sounds like, yeah.
Why don't they just do it prospectively then, though?
Yeah.
Anyway,
But
okay.
So, and I think this kind of goes to your point, like the people that met inclusion criteria to even go on this protocol, there was a subset of 37 patients. So that was decided when they were doing the consult, right? Like not retrospectively when looking at it, but when they were looking at who they were actually going to publish in the study, that's where they started to exclude people like whether they had been on methadone, whether they a few transitioned to buprenorphine after starting on methadone, and then there was a few that had patient-directed discharge before even getting their methadone dose. No one included in this study had any of those adverse effects, so that's definitely a notable part of their results. So nobody required a methadone dose to be held. No one had a higher level of care. No one got administered naloxone. And then 4 of the patients that were in that N of 25 did leave the hospital by patient-directed discharge. Sorry, and I put some of those results in there before the demographic table, but this kind of goes through all of these patient characteristics in a little bit more detail. We already talked about it being kind of a younger age group, predominantly male, predominantly white, predominantly non-Hispanic. Kind of a mix of admission diagnoses, pretty typical of what I've been seeing at HCMC for our consult service. A lot of Medicaid patients, a lot of housing insecurity. About 50% have a co-occurring methamphetamine use disorder, and about 25% were IV users of fentanyl. And I think another thing that's pretty notable about this characteristic is the prior methadone on the bottom there. So 80% of people had been on methadone before and had had experience with methadone.
And they're in the hospital for 14 days?
Yep,
Wow.
plus or minus 10, so
Yeah.
pretty wide range, but
Yeah, there were some outliers there.
yeah. Which we definitely see when we look at the next table, which is the kind of like meat of the results. So a few things here. So they talk about the average methadone dose, how many patients received the dose, the patients that were getting full agonists, which they said 96% at some point during this period got full agonists on top of the methadone. They have the range of MMEs for that too, which is quite a range, which I think is useful though, to know that like people are tolerating full therapeutic doses of methadone and up to 240
Oh my
MMEs
gosh.
instead out there.
Really? In addition?
In addition, so this is excluding the methadone. But one thing that stands out is 11 of these patients were started on methadone before the consult service was even brought on board. And then only on day 1 and 2 were those N of 25, like, did everyone get the methadone? So people were being discharged throughout this entire point. There was some elopement, but they only followed 16 patients to the end, which I think is notable too.
And how are they determining the full opioid agonist? Was it for withdrawal symptoms? How are they doing? Because even on day 7 out here, we're seeing a lot of full opioid agonists being put on top. I'm just curious.
Yeah,
Or
they didn't really comment on
okay, pain,
why it was,
withdrawal?
but they
Okay.
said that they were just allowed to get other
okay,
full agonists. So it made it seem the way it was written that the primary team was ordering those full agonists for other indications. And I
okay.
guess if we're going back to the demographics, we have a lot of trauma.
So it might not have been for withdrawal syndromes. It might have been more like for other indications for acute pain.
That's the indication I got. Because you're right too, like it seems like the MMEs almost ramp up towards the like
Yeah.
later days in the hospitalization. But I don't know, they didn't really like do a deep dive into that. They do get to quite high doses of methadone by the end of day 7. So if your average person is getting 96 milligrams, that's pretty notable. Let's see, I have the average discharge dose of methadone was 113 milligrams, with a standard deviation of about 30. So that once again is a pretty good range
Wow.
that most patients were
Mhm.
like a pretty good dose that most
Yeah.
patients were discharging on. We talked about no adverse effects. And then I think one of the really tricky parts with this study is they talk about no adverse effects during the hospitalization, but it's really hard to judge adverse effects after the hospitalization. They said that every single one of these 25 patients had contact with the healthcare system at some point within the next 8 months. And when they looked at their charts, they didn't see any like methadone related concerns. So they didn't think they came to the ER for like being overly sedated on methadone, that type of thing. But I feel like that's kind of a loose
Yeah.
metric and definitely could miss some things there.
Especially since we worry mostly about the first couple of weeks,
Yeah,
you know, for the first week.
yeah, absolutely. Limitations, so I think there's a ton of limitations for this study. It's a pretty small study. This is an inpatient study only. There's a pretty specific patient population that we're looking at. It's a retrospective study. There's no control group. It's unblinded. We don't really know the reasons for the self-directed discharge. And I think in the discussion section, they comment on like the idea that rapidly titrating somebody onto a higher dose of methadone would in theory prevent elopement and encourage people to like stay for the duration of their medical treatment. But we don't really have a second group to compare that
Yeah.
to see whether that's true.
It'd be
or
interesting if
not.
they had previous data of what their level of discharge was in their prior
Yeah,
protocol.
exactly.
And what's their previous data on how many actually made it into an OTP later.
Yeah.
To compare. Yeah, that'd be nice.
So I think like in theory, that sounds like that would happen, but we don't really
Yeah.
know. Heidi talked about yeah,
I assume they, facilitated a transfer to an OTP, right? For
that's what
them,
they didn't
when
talk
they
about
left.
really either. They said that they utilized the 72-hour rule to bridge people to an appointment, but they didn't really get into like their follow-up rate or
Yeah,
like whether they were following up with people in an OTP. So I feel like that's still a question mark.
so you mean they discharged them with 3 days of methadone?
Yep,
And then within that time, presumably they were supposed to get hooked up with some OTP,
Right.
but, okay, so we don't know if they did.
we don't, and I feel like if you're thinking about the benefits of the rapid titration protocol, that certainly would be one of them. The thought would be like, if you get people to a higher dose, is there gonna be an increased rate of people showing up for their methadone intake appointments and like improved retention and care? And I don't feel like this study really gave us the answers to
Seems
that.
like that would be the main.
Yeah.
I mean,
Yeah.
that's the main reason to get them onto methadone, right? So
Yeah.
that they stay on methadone.
I think this study was just trying to say, we ramped them up faster and no one,
And we could do it.
like, this
Yeah.
is just.
While
we had
they were
safety.
there.
Yeah, just
Yeah.
if we were here,
We didn't overdose.
no one
anyone
overdosed. That's
in the
basically what it,
hospital.
that's the limit, that's the scope. of it.
Yeah,
Which is still
Yeah.
important to look at, right? Because it is an otherwise scary thought, so.
Yeah.
yeah.
And I think
But then you've got all
the
those extra opiates that they were getting too. I mean,
Yeah,
that's,
opiates on top.
I don't understand that, I mean, if they were on methadone, why wasn't that controlling pain or taking care of their withdrawal or, I mean, it would seem like the extra opiates should be decreasing as the 7 days as their dose
Yeah.
methadone increased, and it didn't look like that.
You're right, and it
In
would
fact,
be
it increased.
to see the intervariability in that, to see if like the patients on the higher methadone dose were on the lower end of the MMEs within that range. I think the overall trend is that the methadone dose goes up and that the MMEs go up as
Yeah.
well.
Yeah, yeah.
It seems to be stable. Yeah, it
Which
depends
is-
what was going on with these patients, if they were, had massive trauma and they needed a lot of acute pain.
Right. Or
Methadone
we're having
recovery
surgery or
or
something, we don't know.
Yeah, we don't know.
But
Yeah.
still, I mean, that would not be the goal. That, the goal would be to get them just on methadone, right? So, So it seems like this is sort of a group of patients that, you know, were not really being transitioned to maintenance methadone, in my opinion. But, but, you know, it's still of interest that they can do a more rapid
Mhm.
induction. And I think that, you know, well, I'd be curious to hear, go ahead and finish, and then we can maybe hear from some of the other people who are doing inpatient
One of my
consults.
One of my thoughts to what you were talking about with the increase of the other full agonist opioids, kind of closer to days, 5, 6, 7, is nursing like familiarity and also feeling more comfortable with giving things on top of the methadone. They also didn't really, they also didn't, it'd be helpful to know, like, did someone get admitted, they got on methadone, and then they had a painful surgical procedure, and so then the amount
Right.
went up.
Yep.
But I found quite a bit that it took some convincing of nursing to give opiates on top of subtherapeutic methadone doses. So I don't know, it's just a thought, but
That they're getting them because of subtherapeutic methadone.
Well,
that
the increase is due to nursing comfort as they get used to the fact that it's okay to give opioids on top of methadone.
like
I
just
gotcha.
having a conversation with the nursing staff and saying, you really don't need to worry. This patient is on 50 milligrams of methadone, and you could give them,
Yeah.
10 of Dilaudid and they're barely going to feel it. And so like you almost as a provider have to like really advocate that they'll be okay.
Yeah. That their opioid tolerance for fentanyl is so high. Yeah.
Yeah. And then you also like, I don't know if any of, I guess it excluded patients who were transferred to the ICU, but did they start out in the ICU and they had Dilaudid drips, or like, it's kind of hard to know what each individual case was. But sometimes I would see when I was using short acting on top of methadone that there'd be this increase a couple of days into it and then gradually decreasing. So I'm a little surprised that by day 7, it wasn't really like dramatically decreasing.
Yeah.
Yeah.
All right, I have a few more slides. So conclusions, rapid methadone titration is possible and safe. I think one of the keys to this is that it was done with very careful patient selection and was done in an inpatient setting. And then we kind of already talked about this already, but the fact that they kind of calculated the MMEs and there's such a wide range, and then still there was no adverse effect in that group, I think really points to the fact that these patients have such high opioid tolerance that they're going to tolerate a rapid titration on methadone.
Mhm.
And I think we're going to see a lot more studies on this. So these are 3 studies that I just found with a quick search, and they've all been published in the last 2 years. And they all have a different protocol that they're using. So there's just like a lot of intervariability for what hospitals are doing and what they're calling a rapid methadone initiation. This first study on the left was actually using a protocol pretty similar to what this study that we're talking about called the standard protocol. So they started at 30 milligrams, increased by 10 milligrams daily until you got to 60. So that's pretty much the protocol that we reviewed at the beginning that was called the standard protocol, but yet this study is calling it a rapid protocol.
Was there adjusting daily instead of every 3 days, I guess? So we used to do every 3-day adjustments. Or
Really?
even smaller doses. I mean, that was some of the,
Yeah,
yeah.
so I guess like
And generally,
rapid in terms of historic, what
Yes,
we
yeah, that's what you're comparing it to. Yeah.
yeah, and generally in the outpatient OTP setting, I mean, they're only changing the dose every week or so.
Yeah,
So,
Yep.
this is rapid compared to that, I guess.
yeah,
Mhm.
very good point.
Although now there are a few studies that you'll see. I think one was an ASAM Weekly this week on rapid outpatient titrations, kind of in anticipation of potentially seeing the SAMHSA change guidelines. And those studies as well have been favorable. I mean, if you select patients appropriately in the outpatient setting as well, the studies have showed a pretty good signal for safety too.
So, so a lot of these, this is Cole speaking. So a lot of these protocols have been developed over the past 5 years and are just now being published, hence why they're all retrospective. There's about 6 to 7 hospitals across the country that have developed these. OHSU, which I think is this,
Mhm.
which you just presented, is just one of them. There is
Yeah.
no accepted method. They actually started presenting these at ASAM about 3 or 4 years ago. There is no literature base. There's not a lot to stand on when you actually do this, and hence why there isn't any more organized prospective studies. Is it's all retrospective because they're meeting the patient need, because it's a need that's occurring right now because of the fentanyl epidemic and people's profound tolerance. The outpatient, methadone guidelines are not meeting their needs. And you had mentioned like what a typical outpatient methadone ramp up, and people correct me if I'm wrong, that is way faster than any methadone clinic I've ever seen increase people on methadone. Even the fastest methadone clinics I see, at best, it's like 30 to 40 and maybe 5 to 10 a week. If you have someone on a therapeutic dose of like 150 milligrams of methadone a day, which is not infrequently what people need in the fentanyl era, isn't going to take a lot more than 2 weeks to reach a therapeutic level. It's going to take months, at which point they're consistently using typically injection fentanyl or injecting fentanyl or you name it on top of methadone. I could go on and on, but I just want to emphasize that it's like you can do this. I think it really does meet a unique patient need. That the old laws for methadone are archaic, created in 1970s and not based upon the actual pharmacokinetics of methadone. And that I think I think that within the next couple of years, you're going to see the evidence base for these. I've probably done 40 of these ish in the past 2 years up in Duluth with, I don't want to make it about what I'm doing up there, but it's with way more aggressive dosing. And they just pick 60 and start at 60. Why not pick 70? Why not pick 50? And if their opioid tolerance is astronomical from chronic fentanyl use, I don't understand why they wouldn't need short-acting opioids to help, whether it's pain, withdrawal, you name it. I still can't distinguish between acute pain and withdrawal most of the time. I've never really met someone who could. I think it's so messy and murky that especially that acute Dilaudid, or that those massive doses of Dilaudid, when people are at a subtherapeutic dose of methadone in those early days, are almost needed across the board.
What dose do you start at, Cole?
So I picked 60 solely because I wanted a leg to stand on if anything went wrong. I could at least point to the OHSU protocol. So I typically start there, and I go up by 20 a day. I'm treating someone right now, or it depends upon what the history is and how long they're going to be in the hospital. Almost across the board, they're injection drug users for prolonged courses of parenteral antibiotics. So I mean, you could also argue like, why go so slow? Like you get methadone has 2 peaks, one within the first 3 to 4 hours and another one a couple days later. That's a lot less. Like if you know the predominant effect within the first couple hours, like why not? I mean, there's no evidence to suggest that going slower or faster there's no evidence to guide any of it. It's weighing the risks and benefits of over sedation versus, yeah, I'm talking too much, so I'm gonna shut up.
No, actually, Cole, we want to hear more. If you've
Yeah,
done more of
yeah.
this than most of us, it's
Yeah.
good to hear from somebody.
No,
So
I do. Go ahead, Sarah.
You started 60 and then you said you go up by 20.
Yeah, again, this is based on what I've done or what I've had success on. And when I first started this 2 years ago, I was calling people all around the country. I can't tell you how many times Brian and I discussed this. Like it was because there's no evidence base, and it goes completely contrary to the way that methadone had been done previously, but I start at 60. I go up by 20 a day. Once I start getting, and I have loads of short-acting agonists, usually just oral Dilaudid on top of it, usually kind of what they recommend. And the patients, whether it's from acute pain or withdrawal, again, I sure have trouble distinguishing between the two. And frankly, I don't care, because I don't care. Their opioid tolerance is going to be profound. Friendly reminder to keep your pharmacist in the loop about the plan. Yeah.
From the pharmacist perspective of, I could see us being the police on this.
Yeah, and
Yeah.
the other thing, before doing this on anyone, I think one of the shortcomings that OHSU protocol has is, I guess personally with my protocol and some of the other protocol, like Boston Medical Center, like I make sure that there's an opening in the OTP clinic and that they can accept the patient, and that they'll honor whatever dose we get at.
I was going to ask that. Have you had any pushback of sending somebody out on a high dose?
I wouldn't even do it if I didn't have the okay that it was going to be honored. Otherwise, I argue, what's the point? I mean, I think that's me personally. And so I don't.
That'd be an issue in some areas where you get them all set up at a high dose and they go to some clinic where they just
and where I do it, we have 2 OTP clinics in northern Minnesota, so we don't have a lot to choose from. So it's not like, so yeah, they honor whatever dose, and then we rapidly increase.
I think that's key. You know, they didn't talk about that, and we already mentioned that, you know, follow up at an OTP. I mean, you need to be sure that you've got a place to send them, I think, because there's, like you said, there's really no point in getting them onto the methadone if they're not going to have follow-up at the methadone clinic, and if they're not going to be able to use the doses that you're getting them up to. So that's obviously key, I think, working with the methadone clinic. And I don't know how methadone clinics here in town are about that now, I guess, because I haven't been doing this lately. But Ingrid, do you guys use this at Alina? Have you done any methadone inductions like this? Maybe she's not there. Okay.
You know, I was going to say that I have to really agree with what you had to say, Cole. I think we do a grand disservice to our patients when we're treating them with methadone doses that were used, you know, 20 years ago, with, you know, patients coming in with a completely different tolerance while they're using heroin. And so I think, you know, I never had any trouble getting methadone clinics to continue the dose. We always have pharmacy call the methadone clinic and say, here's the most recent dose, and this is, I've never heard that it's been an issue. Nor have I ever. So one of the things on the inpatient side that's completely different than the outpatient is that you can split dosing. So if you give someone 40 milligrams in the morning, 4 hours later, order another 10 milligrams, another 4 hours later, order another 10 milligrams, and you're splitting it up, and you're going to be able to see their response. For a lot of these folks, when I was increasing them quickly on methadone, I'd be rounding on them 3-4 times a day just to kind of touch base and see what they look like. You end up saving time by seeing them frequently and talking with the nursing staff about how they're looking. You know, knock on wood, I never had to order Narcan for someone. The tolerance is just out of this world.
I think that was a huge component of the studies as well. Like, what I really took away is like, I expected when I started doing this that there was going to be a lot more you know, overshooting with sedation. It hasn't happened, or if it is, they'll sleep it off for a day. And usually when I increase by that 20 a day, it's after an evaluation to see if they're sleepy, and a lot of based on what the patient's actually saying. And once they get closer to that therapeutic level, it's almost like a light switches, like they're
Yes, and what I have found is that patients who are on the other short-acting full agonist opiates is that they're self-tapering. You know, they're not asking
same.
for more, and they just suddenly are feeling so much better. They're not looking for that euphoria.
Totally agree with you, Sarah. That's been my
Yeah.
experience across the board. I've never had to discharge them with additional Dilaudid, and I think it just speaks to the messiness of trying to distinguish acute pain, real reasons for acute pain, in the setting of acute severe with opioid withdrawal.
So do you
And
typically get to
severe
about,
tolerance.
What's
Sorry,
that?
go ahead.
get to about 100 milligrams, or where is your usual end point?
I start getting anxious based upon zero evidence that once I get to 100, but I'm becoming more, depends how long I can keep them there. If they're going to be there. If they're there for parenteral antibiotics and they're not a good candidate for outpatient parenteral antibiotics, and they're going to be there for weeks, then I can go a lot slower after I get to 100. But if they're
I
going to
also
be,
think, oh, sorry.
no, go ahead.
I also think it depends on, have they been on methadone before? What was their dose at the methadone clinic and when was it? So if you have someone who was on 150 of methadone a month ago and their last dose was 1 month ago and they were out using IV fentanyl, you know, yes, they may lose some tolerance depending on how much IV fentanyl they were using, but their brain is going to have some tolerance. So I started worrying, like I started slowing up how quickly the increase was happening. I wouldn't give someone 20, increase them by 20 milligrams a day if they're already at 100 over the course of 5 days, but you can give them in tinier doses. Maybe you give them 5 milligrams TID PRN for a day or two and see how much they use, while you're still continuing the full agonist if they need it for like a post-op pain or something. But you can also decrease the short acting knowing that you're increasing the long acting.
I've also found that kind of goes counterintuitive to a lot of like the dogma that I learned is this goes with treating withdrawal in general. Like I find the subjective withdrawal symptoms profound in opioid withdrawal, particularly from fentanyl. I don't know if there's something pharmacologically to it, but regardless. And so I frequently give scheduled lower doses of diazepam to these patients. And they ended up receiving quite a bit less of the short, it's the subjective anxiety potentially surrounding, well, withdrawal or whatever it is. But I find that things go a lot smoother with a little bit of diazepam. Again, diazepam in these profoundly opioid tolerant individuals.
What dose of diazepam are you giving out of curiosity, Cole?
The one I have upstairs right now is on 5 milligrams TID and PRN. So I would do 5 to 10, but I guess I think that was a
You're a
great
monitored setting.
presentation.
I think that makes sense.
Yeah,
I mean,
the setting makes
they
a
had their
difference.
place in relieving a lot of these symptoms from opioid withdrawal. I think that does make sense. Yep. But it's a monitored setting. I do mainly outpatient, so that's why it's a little bit different for me in that sense. Yeah.
I like diazepam, especially at bedtime. I mean, I would sometimes give 10 at bedtime and then kind of try to avoid extra methadone overnight when there are fewer staff. But again, I, knock on wood, never overdosed anyone using diazepam with it. So
Do you guys have a pretty similar like exclusion criteria in your mind? I'm getting the sense that maybe you guys are a little bit more liberal compared to what they did in the study of excluding all of these patients.
I can almost guarantee that they were a lot more liberal at OHSU, and that's just what they've published, is those strict exclusion criteria, because they were doing this for many years before they published that subset. And
I'd say if someone's in benzo and alcohol withdrawal, then I'm trying to push heavier on phenobarb or, diazepam. But the thing is you also want to, if you've got someone an opiate and alcohol or benzo withdrawal, you really want to get them up on a therapeutic methadone dose if you can, because then you also can kind of clear out the muddy water to determine what is alcohol withdrawal versus what's opiate withdrawal. I've frequently received consults for difficult to control alcohol withdrawal on day 5, 6, or 7, and the reality is it was all opiate withdrawal. So they were getting benzos and they
Yeah.
were getting, ongoing pretty high doses of benzos, but then you give them Suboxone or methadone and suddenly their alcohol withdrawal goes away.
Mhm.
Or their CWA scores go down, I should say.
Yeah, I treat each of the withdrawal syndromes completely separate. I mean, especially if it's alcohol or benzo withdrawal, their GABAergic tone is through the roof as well. So it's not like
Mhm.
Yeah.
the medications that they're going to require are just going to be much higher. I do strictly follow that, basically cardiopulmonary disease. If I'm concerned about the medical comorbidities, or I'm concerned that they're just not going to follow up at all in OTP. Usually it's these really high risk patients that I end up doing this on. If they're going to be a complete nightmare to the methadone clinic and the methadone clinic doesn't want to deal with it, then I don't consider it.
Have you guys gotten pushback from the nurses about, these high doses of methadone and then giving additional opiates and stuff like that?
I got pushback from everyone, but
Pharmacy.
not anymore.
Yeah. Pharmacy, nursing staff.
Yeah,
But I think if you just spend the time to explain your reasoning, and that's where I found frequent rounding and swinging by and actually having a face-to-face conversation with the nurse and
yeah,
calling pharmacy and explaining the reasoning and knowing, okay, I'm gonna have eyes on this patient more than once, or let's put them, if you're really worried, continuous sat monitoring, if do they need tele, okay, you'd feel more comfortable with an EKG. Okay, I think that seems reasonable because they're also on Seroquel or whatever it might be. I think you want your nurses to be comfortable too. And depending on the hospital, they might want them transferred to the ICU just to do this. A small hospital, when I rounded at Fairview Lakes and Chisago, they'd want a patient like that in the ICU just to feel more comfortable, and that's fine.
yeah,
Even Mercy Unity, they have different criteria, so.
yeah. I think it would take some nurse education as well, around this.
Some of my longest notes, I even have kind of a smart phrase I use for this, are explaining this reasoning so that people can
Read
look
it.
at it. Yeah, so people can read it.
Yeah, that's good.
This is Danielle. I'll add in the pharmacy perspective, in that it's what we've already hit on of, if you haven't seen it, you go to look something up, there isn't information out there. Like all the resources that you find are going to come across very concrete of like, do not exceed this dose, do not do
Right.
this.
Right.
And so it really is that conversation of the explanation and, yes, I am going to check on this patient, because the other side is there are people in hospitals that will just order methadone to, relieve some withdrawal and don't have, we'll say, the nuanced expertise behind it.
Yeah.
And so you also want guardrails in place to prevent,
Yeah, I mean, I
that
would
going
say,
to an extreme.
exactly. This is something that probably needs to be done by an addiction medicine consult, or an addiction medicine specialist to manage these kind of doses and stuff, if that's at all possible.
Yeah,
If we
and
get enough of you
unfortunately, the
guys-
reality is addiction medicine
Yeah.
isn't in all our hospitals.
All right, right.
If you have patients who are, you're worried about the benzo and alcohol and you're using phenobarb or whatever it is, or Valium, I mean, are you going to bupe standardly instead, Cole, or are you finding just it's not?
There's never, every single one of these patients, I should say, like try my damnedest to, or try my best to make sure that, or convince them to go on buprenorphine, because their life is going to be easier, even if it's daily dosing at OTP for that accountability and structure. Like, I always try to convince them to go on buprenorphine. It's usually only when
Gotcha.
they only want to do methadone for whatever reason, frankly,
Yeah, fair.
that I do this.
Yeah, I'd just be more personally worried about doing, a rapid methadone if I'm also doing a bunch of, management of benzo and alcohol together. Just
Yeah,
me,
I get more worried.
I don't have the level of
Yeah.
expertise personally, I think, so that's all.
No, I do get worried, but I do try to really separate out the processes and remember that their level of neuroexcitation or their pharmacology is different from everyone else's.
True, fair.
That was a
Taylor,
great
any-
presentation. That was a really
Yeah.
good
This
presentation.
is a really
Great
good
topic.
topic to
Great
discuss.
topic.
Yep.
Great.
Yeah.
Mhm.
Clearly,
Very quickly.
these things are changing. We're, fentanyl is the standard out there now, and we need to be able to manage it better, I think. Taylor, is there anything else you wanted to add, or any other slides that you had here?
I think I just had some references at the end, but we got through all the materials, so yeah.
Okay.
Awesome conversation. This is great.
Yeah, thank you for this topic, and I think more to be revealed, right, about what SAMHSA is doing and what methadone rules are going to be, if they're going to be modified. So
Yeah.
so that's of interest too. Any other comments, questions?
Cool. I'm Chris. I'm one of the other addiction medicine fellows. I was wondering if I could reach out to you just to get some insights on the way that you've been using methadone too. That just kind of like, yeah.
Can he email you?
Sure.
You guys are welcome to email. I'm sure I speak for everyone, any of us, including myself.
Thank you for the expert opinions. They actually really make a difference. So thanks, everybody.
Yeah, and for your experience, those that have experience, it's great. All right. If nothing else, we will end. Please send the slides and the article, Taylor,
You got
to
it.
me, and so we can get them on the website. Thank
Yep,
you.
I'll do that right now.
Okay, bye. Good to see you, Cole.
Nice to see everyone.
Okay, take
Bye now.
care.